Welcome, everybody. Welcome to another episode of PEM Rules, the Pediatric Emergency Medicine Podcast. I'm your host, Yaron Ivan, as usual, and today, some more important rules in the clinical care tips category. Rule number 162: get the test for the wrong reasons. Now, obviously, in life, certainly in medicine, we really don't want to do anything for the wrong reasons. It's a bit of an ironic phrase. I don't really mean the wrong reasons, but sometimes we should get the test really not for the main goal that it's actually used for. And obviously, we'll explain with an example. And this is actually a true story that happened to me not too long ago. So, a few weeks ago, I saw a child in the pediatric emergency department who came in with a knee laceration. The laceration did not look particularly deep, and I can tell from the physical exam and from the history there was a penetrating trauma, not a significant trauma, not a significant blunt trauma involved, and I was not at all concerned that the patient has a fracture. Beyond the laceration, I got a normal physical exam. There was no swelling, there was no tenderness. The patient had some tenderness over the laceration, but he was able to move his joint well, he was able to flex the knee, extend the knee, etc. So I really, in my mind, had no reason to get an x-ray. As I've discussed in PEM rules in the past, x-ray is really meant to visualize the bones, and if you're not concerned about a fracture, I tend to avoid getting an x-ray for the radiation, for the cost, for the time, for whatever reason. I'll spare you the details, but at some point we did get an x-ray of the knee, and to my very big surprise, there was air in the joint capsule, which indicates a more penetrating injury, a more significant injury that really means the orthopedist should be involved. Now, needless to say, I was very surprised by the x-ray results, but it also made me realize, well, you know what? X-ray can really be used to look at other things other than the bones. Now, this is something we all know. We often use x-ray to look for air under the abdomen and for air fluid levels, etc. But it really did not occur to me x-raying the joint, aka the knee, really can help you assess the severity of the penetrating injury with regards to air in the capsule. Good lesson, good learning opportunity. Another good example for this rule is obtaining a CBC on a child with an unusually bad infection. Yes, we all know when this child has a fever and what you think is a severe infection, yes, he or she are likely to have leukocytosis. As I've mentioned in the past, it doesn't really help you understand how severe the infection is. It doesn't necessarily tell you where the infection is. If the child is febrile, you already know he or she have an infection. It's not a test that indicates the site of infection. However, a CBC in the setting of a severe infection can also indicate leukopenia and maybe the presentation of leukemia. So although you think you may find leukocytosis, which you already know the patient have, you actually may find leukemia. Another good example is the child who presents with prolonged fever with really no signs of UTI. Patient has no frequency, urgency, and you're really not worried about a UTI. However, the urine analysis may indicate sterile pyuria, which may clue you in that this patient actually has Kawasaki. So a urine analysis is not always used to look at UTI, just like a CBC is not always used to look for leukocytosis, just like an X-ray is not always used to look for fractures. So remember rule number 162. Get the test for the wrong reasons. Again, not really the wrong reasons, I'm just using it as a phrase. Rule number 163. Inquire if there's anything new. In emergency medicine, I personally find that this is a key question to see if you're missing something. Many kids come to the pediatric emergency department with chronic symptoms, chronic disease, and asking if there's something new, without being dismissive, of course, can really go a long way. It helps you find out if there are any recent changes that you need to know about as a clinician. That can help you pinpoint the concern, pinpoint the problem. It's just a matter of getting good history. A good and obvious example is the child with history of epilepsy who comes in with worsening seizures, despite taking the medication that he or she needs to take every day. This could be as easy as recent weight gain and patient needs adjustment to the medication. Maybe it's a matter of patient is not getting enough sleep, body is in stress, and that can clue you in why maybe the patient is having exacerbation of the seizures. This is also a very important question that I find very helpful in kids who present to the pediatric emergency department with anxiety, depressions, etc. Maybe there's just something new in this child's life, some kind of stressor that is pushing them over the edge and making situation worse. As a physician, as an emergency physician or clinician, I think it's always very important to inquire if there's anything new, especially in the setting of a chronic disease that seems to be exacerbated. Rule number 164: know what not to do. So I think we emergency physicians and clinicians often think of ourselves as doers. We like to do stuff. We take a history, we get a physical exam, we order tests, sometimes we do procedures. But I think in medicine, especially in emergency medicine, it's often very important to know what not to do. And it's often very hard for us not to do things. Probably the best example for this is the issue of over the counter cough and cold medications, which are readily available at CVS, Walgreens, and any other pharmacy. So, viral illnesses or URIs are probably one of the most common cause of ED visits. We see a lot of kids with fever, cough, congestion, aka viral symptoms. And the American Academy of Pediatrics is very clear and it has always been very clear that over the counter cough and cold medications are not recommended for kids. Number one, there's really no evidence behind it. There's really no evidence that they help do anything. Number two, having them at home is the perfect risk factor for accidental ingestion, which we see all the time. Those medications are very nice and tasty, sugary, colorful. It's the perfect situation for that 3-year-old toddler to go into the cabinet, drink the whole thing, and come to the pediatric emergency department. To my knowledge, the American Academy of Pediatrics recommends against those medications, and that has been the situation for many, many years. Another good example is the use of antibiotics for bacterial gastroenteritis. So, bacterial gastroenteritis, most commonly caused by Salmonella, Shigella, and Campylobacter, and most of the time, if you read the guidelines, there's really no indication for antibiotics. So, for example, Salmonella in a healthy patient over 6 months of age with no past medical history, antibiotics are not recommended. Specifically with HUS or hemolytic uremic syndrome, to my understanding, antibiotics can make matters worse. So it's actually very important to know what not to do, just like as it is to know what to do. This, I think, is specifically true in pediatric emergency medicine or pediatric medicine in general, where kids just get better on their own. And sometimes it's beneficial for us clinicians to stand back and just let the kid get better. So remember rule number 164: know what not to do. Medications for the common cold, antibiotics for bacterial gastroenteritis, etc. And that is it for today, guys. Thank you very much for listening. Let's review briefly what we learned. Rule number 162: get the test for the wrong reasons. Remember, CBC is not always used for leukocytosis. You may find leukopenia, which will clue you in that the patient actually has leukemia or lymphoma. X-ray doesn't always look at the bone. You can find air on X-ray, and maybe you'll find air in the wrong place, which will indicate a surgical intervention or at the very least consultation. A child with prolonged fever may have Kawasaki, and although you're not worried about a UTI, a urine analysis may clue you in that the patient has sterile pyuria. Sterile pyuria, unfortunately, goes along with Kawasaki disease. Rule number 163: inquire if there's anything new. In emergency medicine, we often come across patients with chronic diseases, chronic conditions, and asking if there's anything new basically translates to is there anything acute or subacute on a chronic condition. This, for us pediatric emergency medicine clinicians, can be very helpful to see, to inquire if there's something that we can take care of, test for, consult for, etc. Rule number 164: know what not to do. I think as physicians and clinicians, we often have the reflex to do something about a problem, but it's very important sometimes to know that some things we can do can actually be harmful. Again, a good example is antibiotics for bacterial gastroenteritis, medications for the common cold, which really have no use. So, know what to do for your patients, but also know what not to do. And that is it for today, guys. Thank you very much for listening and supporting PEM Rules. I appreciate it. I hope you check the website, check EP Monthly. I also have a Facebook page now that is semi active. I hope you can visit the page and learn from some of the educational materials I put on there. Have a great day. Thank you very much for listening. I hope you like this following outro. This is called Bound to the Floor by a band called Local H. I can't say I'm very familiar with them, but this is a great song with a great guitar riff. Hope you like it. Have a great day.